All right, everybody. So today we have a wonderful guest with us. I'm not going to actually do the intro. Going to let her do the intro. But today we're going to talk a little bit about all these hoo-ha that's obesity medicines and just in general obesity. So I've always known her as Steph, and that's who I talk to her about. But Steph, before we go any further, do you want to introduce yourself to our listeners as to who you are?
Okay, I am indeed Steph. I am also Dr. Stephanie Dejo. I am a GP and I work down here in East Kent, so I'm kind of nearer France than most of England. I'm a GP, so I do that mostly in an urgent treatment centre setting at the moment. And I have a special interest in obesity and women's health. So I have spent the last 8, 9 years now, I think, talking and teaching about obesity and being a patient advocate, being an advocate to try and get change.
Yeah.
And I love it. I like kind of doing the slightly less trendy bits of medicine.
Yeah.
And so for me, obesity has been a personal and professional kind of crusade, so to speak. And I care hugely about trying to make things better for people.
Yeah, and I think, without blowing smoke too much, I think I've always sort of liked your straight talking because I think that resonates quite a lot. I mean, for those of you who don't know, Stephanie was famous, first of all, for challenging Jeremy Hunt. So that's great. I love that. I love that
Yes.
fact that that's what I like. And my whole philosophy has been based on that. You should not be afraid to speak what you think is not right. And I think the system tries its best to shut you down. So I do admire a lot of that, and that's great. So, which brings us nicely to this. And I'm going to come back to your personal story, obviously,
Yeah,
which
no,
is
that's
your
fine.
personal interest. But I think there's a lot of talk in the media about obesity medicine, and I'll give you my uncluttered view on it, which it feels like a bit like a shit show to me. So
Yep, that's about right.
well, how do you see it? I mean, the drug itself, and I think just to sort of for the listeners, let's make it very clear. This is not sponsored by any companies. We
Yep,
haven't taken any. This is just us. There's no
yep,
sponsor. This is our own personal view.
yep.
So, and Steph is doing it just as a friend, as a colleague, and as I was said, because of her interest in trying to help in the space. So, what do you think about this drug? Well, the drug's what it is. There's two sides to it, isn't it? It's the wonder drug, and the other side is why bother with the drug at all when all you need to do is eat less and run more. So.
Yeah.
What's your
So,
what's your perspective on it?
so I think that the drugs are a game changer. They're a game changer for people living with obesity and probably people with living with other things as well, which we're finding out more. I I have at some point done some work with Novo, so I should declare that. And I have done teaching and things with them. And then tirzepatide came along, and that kind of changed things again. So we've got semaglutide, we've got tirzepatide. I think what's been fascinating for me is knowing that these drugs are more effective than most drugs that we prescribe for most things. Yes, they have side effects, of course they do, and they have to be prescribed to the right people in the right way. But the thing that is fascinating, there's two things that fascinate and terrify me. One is that we have about 1.5 million people taking them privately. And I don't think, perhaps apart from Viagra, there's really been anything else that has
Because
been
that's
so
yeah, right.
available privately,
Mm,
and with very little medical oversight.
yeah,
And then the thing that scares me as well is that we are just getting a two-tier situation now. So
right.
we are getting the people who might need it most are not able to have it because they can't afford it. You know, you're talking about 150 to 200 quid a month. And people on the NHS is weeing its pants over what to do, quite frankly. And it's all got a little bit messy.
Yep,
But the drugs themselves, I think there's 19 other drugs in the pipeline. This is
yep.
not going away.
No,
So and that really annoys a lot of people as well, because
yeah,
there are whole industries based upon it being really hard to lose weight and maintain weight loss. So I think it's fascinating.
absolutely. So true, so
Sorry, there's
true.
a cat who is just going to
That's
keep
all right.
wandering
That's
into
what's
the
good about
kitchen.
the podcast. That absolutely
Okay,
haven't.
good. Phew.
But no, you're absolutely right, and I think it's sort of the weight loss industry thrives on that, doesn't it? On the
Yeah,
fact that, but apart from the whole bit about why are you not eating my diet that I tell you to, and shame on you for doing it.
Yep.
I think it's one of those things where they've now found out, hang on a second, there's actually something which will beat whatever advice I give you. And that's been
Yeah.
a big, big problem for them. So there's a lot of denigration of the drug trying to go on for their own
Yeah.
benefit. And
Yeah.
do you know what I find fascinating is that, so I go to meetings and they're like, drug, got to give it to, how long do we give it to them? You never have this debate. I think the main thing, my view has always been, I think it's because the system slowly moving towards in a slot-like fashion just will not accept that it's a disease. They will
No.
just not
No.
accept it. It's a social condition, thereby it does not need treatment, is the narrative.
Yep.
And that's what kills it completely.
Yeah.
But you know what the honest and the fun bit is that I still would have accepted that if they'd done anything to correct the social determinants.
Yeah.
Nobody
Exactly.
does anything.
Exactly. You can't say this is not a disease. This is people being lazy and poor because your postcode is the biggest
Yeah,
determinant
yeah,
of whether you have
yeah.
obesity.
Mm,
Um, if they had said, right, we're going to look at prevention and we're going to do treatment and we're going to separate them and we're going to be good. But no, we're going to ignore it. And then when something comes along that works, we're going to scare people. The
hmm.
papers absolutely adore a bad story
Yep,
about one of
yep,
these meds. It's like
yep,
literally crack for them.
yep.
Um, and and I don't think the NHS and the government knows what to do because there isn't such an inherent weight stigma in society generally,
Yep.
and that feeds through to medics and it feeds through to politicians,
Yep.
and they don't understand. They don't know, and
So
and so it's a disaster at the
I,
moment.
I- will tell my listeners and you a story on this one. So many years ago, I had done something called Language Matters in Diabetes, and I was
Yep.
asked by the central team, "Well, why don't you do something for obesity?" And I said, "Yeah, sure, sure, sure." So we got some people together, tried to, and then there was this thing about saying that you can't call them obese, and it was like, no, 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 we need that bit to be taken out because what. And it was just fascinating to see how their views were so different at that point of time. And eventually, believe it or not, NHS England refused to give their stamp on publish. So if you see the Language Matters document, which is
Yeah,
out
yeah,
there,
yeah.
there's one in diabetes, which has got my name on it, NHS England. There's another one out there which never got the NHS England stamp. So it came out independently, even though it was
Wow.
done sort of corralled by me, it's same thing, but they just would not give it the stamp because it was never quite
Yeah.
politically correct or uncorrect, so to speak. So that's fascinating. Tell me a little bit about, you mentioned a little bit about your personal story. So whatever, however much you want to share. Why is your personal? I mean, I can get the professional side because you
Yeah.
want to correct it. Is there a personal angle to it as well that you bring to the whole picture?
Yeah. So I I've always been someone who's slightly sort of struggled with their weight, up and
Mm,
down, up and down.
mm,
Um, had one baby, it kind of got a bit worse, had another baby, got really bad, mixed with, really bad postnatal depression and all
mm.
sorts of other things. But I'm also a really determined person. And if I set my mind to something, I'm gonna do it.
Do it.
Nearly swore then.
Mm,
And I couldn't lose weight and keep it off.
mm,
I did pretty much every diet that's gone. I've done the dust diets where you have the pretend food, and oh my God, that's just the smell even now makes me feel sick. And so I decided to have bariatric surgery, which was a huge deal for me. People had very weird reactions to it, and
mm,
that was fascinating.
mm,
It worked. It worked really well. Then I got long COVID, and then weight started coming back on because I can't exercise. And so then I started my sort of trying the GLP-1s to see what was going on. And I think the thing for me was that I had such weird responses to my surgery. People could not cope that I wasn't just trying Weight Watchers again.
yeah.
Um, People were mean, properly mean. And the other thing I realized was when I had then lost the weight, I got jobs that I'd wanted before
Mm,
that people wouldn't give me when I was bigger. I got speaking opportunities that I didn't have when I was bigger, but I'm the same person.
yeah.
And
Yeah.
this is why I
Yeah.
hate before and after photos
Yeah.
because it's the
Yeah. Oh,
same person.
yeah. With the same
Um,
knowledge and the same brain. So yeah.
yes, exactly. And I
Mm,
was judged so differently.
Yeah.
And I also couldn't keep the weight off. And the first talk I ever did was called Getting Fatter, Trying to Get Thinner,
Mm.
because that's what was happening. I just kept going up and up and up
Yeah.
and I thought, right, if I can't do it with the privileged background of my knowledge, an income, a job that, yes, is stressful, but I don't have to do night shifts anymore. If
Hmm.
I can't do it with all of that,
Yeah.
not because I'm special, but because I recognize that those things matter, then other people aren't going to be able to either.
Yeah.
And it really gave me a kick up the butt, which I
Mm.
needed to say, right, this is something I care about deeply. And I'm in a very, very lucky position where I can talk about it.
Yeah.
I can challenge people, and I have an audience. And so I then decided, this is time for me to start talking about it.
Oh, it's brilliant. I
Yeah,
think people, you know what, slightly sort of segueing out. I mean, people has always asked me, what is the success, what is the reason for the success of influx of funds into type 1 diabetes care? And I keep on saying the same thing. It's got nothing to do with me, right? I give a voice to a lot of people living with the
yeah,
condition. That's all I do.
yeah.
I feel, I mean, I will come back to the sort of situation, what needs to change, but obesity seems to be, and it goes back to the point you said, it's not like these drugs were new or nobody knew it wasn't
No,
coming. It's been around in
no.
conferences for the last, what, 3, 4, 5 years?
Yeah, at least.
I think when I look at the plan, I just go like, what? What were you planning?
Yeah,
Surely you had some planning, right?
yeah.
Because it is quite, and you might as well, I mean, I'm just going to ask your view about the criteria that's come out. But to me, it basically says, look, guys, we just don't have any money, so I'm going to give it to a few select people. That's what the plan looks like to me.
Yeah,
And
that's it.
yeah,
And then there was this slightly weird thing that they were going to give it to people to get them back to work. And
yeah,
it's
oh
like,
God.
oh, that makes me feel a bit sick.
Oh,
Like that's not
oh,
all right. Let's give it to people because they're worthy of treatment, not because it
absolutely.
makes them economically viable. And
I
I
think it's
think,
that thing. Yeah, sorry, go on.
yeah, no, no, no. I found that quite nauseating. And I
Yeah,
think that it really summed up to me that the powers that be
yeah,
still don't believe that people with overweight and obesity
can.
deserve care.
But do you
They
know what
don't.
is even funny? And I'll tell you with my knowledge of how central teams work and
Yeah.
return of investment, even that thinking process is slightly half cooked. So let's say, for argument's sake, right, I want to get all these people who are overweight back into work. Why have you then chosen that they need to have 4 out of 4
Oh,
conditions? Because they will never get back to work if they've got 4 running conditions. You need to make the quality of life better, try and improve. That's what you're trying to do, improve their further outcomes. But so this is what I don't even understand, because if you wanted to use that argument, do you know what? I want to get these people back to work, and if they lost weight, they could get back to work. Well, then you pick people who don't have complications.
yes. Yeah.
Like, I don't understand even
Yeah.
that, but
It's
so with
it's it's bonkers is the only thing it is. It's bonkers.
it
and it's rationing something that could revolutionize
could
people's lives.
it could. Do you know what? I find this, and do you know, I'll tell you my frustration, because I look at it from a very neutral point of view, and I know the NHS can do a significant part of this. Having done a lot of, the funds that I've got is far more than what I've got, what is needed per year for the insulin pumps and all that sort of stuff. The cost of a CGM per year is roughly about the same, and you have negotiated with the industry. So I sit there looking and going like, I don't understand how they have not been able to make the argument, right?
Yeah.
So going back to that point, is that what? So, we have the tier systems, which I've never been a fan of, because I thought they were just ways to stop people from getting somewhere.
Yep. Yep. Absolutely.
What would you, if you had a fresh slate, Steph, what would you like to do? Because what would you do? My controversial view when I had a meeting was, well, you need to decide what you need to stop, and this should be a priority area we should
Yes.
fund, right? Which didn't
Yep.
go very well. So I was like, okay, sorry, I can't contribute any more to this debate if we can't have this discussion.
No.
Um,
I
but
think
yeah,
I think we have to. we have to look at what works because money at the moment is being spent on tier two services that are 12 weeks of a commercial slimming company, whatever.
Yeah.
Um, and then we have to look at this is a long-term thing, and that's what the NHS can't cope with, right? So
Mm,
they can cope with better diabetes control in a child. Like that fits the mark of being good. But
mm,
what they can't do is deal with the fact that if we treat people with obesity who aren't yet poorly,
mm.
then we will prevent all that spend in the future because those people will be more well than they would otherwise have been.
Yep.
And so for me, what somebody needs to take a step back, look at the economics, look at the funding, look at what will be saved in the future,
Mm,
and then work backwards and work out what you can do. But no one wants to do that. It's been done a bit in the States,
yeah.
but it's a bit different in the States because everything's bonkers right there. So, but no one's done it here, and it's because they're scared because they think the floodgates will open and they will.
Yeah.
1.5 million people are taking this already.
Yeah.
Um, but I would do community-based treatment through specialist GP clinics that people can easily access so we don't burden their GPs who are already trying to look after them,
Hmm.
and roll that out fairly speedily, to be honest. And I think at the moment we've now got into this preclinical and clinical obesity debate, which in some ways I know why it was done and I understand that. But what we don't want is it all to be just for the people who are worse with the clinical obesity. We need to get in before that happens. And kids,
Yeah.
we need to think about kids as well. But none of that happens. None of that is going on. Um, and that's really sad. But it
So it's
wouldn't be hard.
interesting. It's interesting you mentioned about the preclinical clinical. So I was at the Royal College of Physicians when the Lancet launched that, and I remember
Yeah.
asking the author the question: "Is that have you not made things a bit more difficult, and you've given policy people like me
Mm.
a way out because you have said clinical obesity needs that intervention,
Yeah.
and all you have done is you have given me a silo to play at, which is how it worked out." And they say, "Oh no, 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 it's on," and so my way of looking at it was to say, when we have money, whatever it is,
Yeah.
from Rachel Reeves and company, say, here's some money to the NHS.
Yeah.
Cannot for the life of me believe that somebody wouldn't sit down and go like, can I have off that 30 billion or whatever it is,
Yeah.
X amount sidelined out to treat the biggest issue that's going to become bigger over the years.
Yeah.
And that's what I've just not been able to figure out because ironically, the NHS is probably incredibly well placed. If you bolster up primary care to do it properly,
Yeah.
you could do it at scale properly.
Fast.
Yeah.
And interestingly, they're not complicated drugs.
No,
Like this isn't like juggling
no,
complex heart failure treatment.
no.
This isn't like doing things that GPs do that are complicated. This is actually easy prescribing.
But we know
And
that from how that's why it's booming in the private sector
uh,
because people are
yeah,
going bang on. So,
absolutely. And I think that there are issues with that. So I
oh yeah,
think that so I'm just launching into that private thing myself
yeah,
because the stupidity of this is with all my expertise, all my knowledge, all my
yeah,
experience, I could not prescribe this to patients on the
yeah,
NHS.
no,
There is
yeah,
literally
no way.
no way for me to do that. And
Yeah,
that is insane
it is.
because because it is. So, we're doing a private company and we're going to focus on the people who are missing out currently because there are cohorts of people who can't get the drug because most things are pharmacy led. So we're going to do doctor led safe prescribing because I
So,
can't tell people to do that and
no,
then not do it myself.
but I'll give you one very good example of locally, and because this is not sponsored by any company, so we
No,
can say we
no.
can talk about it.
Yep,
So locally, I've got people with type 1 diabetes who have had type 1 for 20, 30, 40 years, and they have now got
yep,
obesity. Their numbers, once you step it up, do it in a very careful way, make sure they're not contraindicated, their numbers are phenomenal,
yeah.
right? And you sit there going like, so then you listen to, okay, there's a study now going on, but it's quite fascinating to see. And I think what people discount, it's not the numbers, it's the mental well-being they come back
Oh
with.
my God, yeah.
you know?
Yeah.
Because every
I
single
yeah.
person that I speak to, they go like, do you know what, that hybrid closed loop thing? I don't want that. It's fine. I'm happy with this because this. So
Yep.
I think this is what we've really. Productivity doesn't come from improving somebody's numbers,
Yeah.
you know?
It doesn't. And I always say to people, your weight is just your relationship with gravity. That's not that important.
Yeah.
What matters is how you feel, what you can do. Can you play with your kids on holiday? Are there any photographs of you with your children, or
Mm,
have you hidden
mm,
because you don't want to be in any?
mm.
Are you able to go to a shop and
Yeah.
buy clothes
Yeah.
without difficulty?
Yeah.
And the weight part we'll manage, but the well-being and most importantly, the silencing of the negative inner weight bias, the horrible monologue that goes round and round and round and round, that goes away. And it is literally life-changing. And I don't say that lightly, like it genuinely is. And I think that we forget that. And so for me, my biggest thing is what we call non-scale victories, not what your numbers
Yeah.
are,
But
but
yeah.
what you can do. Can you get on a plane without everyone going, oh, don't sit next
Oh,
to me?
yeah.
That kind of thing. And that to me means everything to people. And that's what I can't wait to be able to help people with.
Yeah.
I'm just sad I have to do it privately.
Well, you know what? I mean, I was basically talking to a few people and I put out some posts. What really annoys me about medicine and science is that it's been gripped by academia and industry to such an extent that people are more focused on getting their papers and their publications rather than actually putting into people's lives. It really annoys me to a huge extent because, and even today, I sort of said, guys, all of you going to the American Diabetes Association, everybody's talking about the other new GLP. Oh my God, there's an oral one, there's a combined one. I said,
Yeah,
okay, all guys, all you're doing is opening up the gaps even wider because
yeah,
none of you have any idea how to put it into lives. And
no,
this is a perfect opportunity because, as you said, there are so much in the pipeline. If you stumble now, you will stumble all along. This is a tide you can't hold back. So
no, no,
you can't hold
it's
back.
coming.
Yeah. And it's here, as you
Yeah,
said, so many people are on it. So
yeah,
I think without that commitment, look, we're going to put X million of people on this drug and, excuse whoever is listening to this and whoever has been part of it, but a 12-year plan to roll out something and a plan. That's basically kicking it into the long grass. Yeah. Isn't it?
yeah.
12 years.
It it really is. And I looked and I was like, okay, more than 40 with four, and then it goes down to 35, but you still have to have the four extra things, and then it goes back up to 40 with three. It's like and then the nutty thing is that we then have to say to people, sorry, you have to get worse
Yeah.
before we can
Yeah.
treat you.
Yeah.
And I at the moment, I think there are 8 ICBs that have actually said they've got a plan.
Yeah.
The rest of them, no plan.
No plan.
It's not a priority, but it so should be. And I would be there like a flash, but nobody listens to this. They're not listening to you, and you are in the room with the
Mm.
people that should listen. They're not listening to me and the other advocacy organizations. They're not listening to anyone. And even people who've got the ear of the people in decision making, they'll say, well, I'd love to do this, but we don't have any money, so we can't do anything. And it just
You know what?
continues.
Uh,
And the gap is going to be so massive.
it is.
And we're also then in this worrying thing where we've got people taking compounded versions that could be
Yep.
full of crud for
Anything?
like
Yes.
50 quid from their hairdresser. That's
Yep.
not okay. That's not okay. But that's a sign of desperation.
Yeah.
And
Well,
that's really sad.
I think, we've touched upon that sort of industry, isn't it, which makes you
Mm.
feel guilty for your weight and stuff. And that's why they're also up in arms. So I think it's fair to say these are drugs which have got really, really strong impact. It has got side effects for which you need
Yeah.
screening and everything and all that.
Yeah.
The plan wise, I think my view, and so going back to the question which I had, is that I think they need to decide this as a priority in the 10 year. If your 10-year plan doesn't have an obesity plan, your 10-year plan is shot because that's not the health of the country, right?
No. And
And I'm
obesity is in every single medical specialty.
And do you know what the irony is then? So I obviously am an advocate of type 1 diabetes. And when people say to me, what do you think? Would you lose the type 1 diabetes side? And I said, guys, if I look at it as a healthcare professional across the country, obesity is much, much bigger problem than type 1 diabetes. I'll do all I can for my area. But for example, obesity is a big problem. Maternity care those are big gun problems you need to solve. And
Yeah.
we have this, and it's interesting you said that. And I just wanted to test this theory with you because I go to meetings, right? And people go, oh, we'll try this AI and this, that, and everything. And my fundamental belief is that person on the street who really, really is getting more and more, desperate and disenchanted with the NHS would
Yeah.
like to see a GP on time, would like to be seen in
Yeah.
A&E on time, would like to know their cancer is picked up on time, and they have access to the biggest problem most people have, which is obesity and things like that. I think if we
Yep.
did that, people would be really happy with the NHS.
They would. It's really not rocket
It's
science. Like
not.
it's not hard to do the things that matter to people. And I kind of work across a lot of those spheres now, and I see all the harm that comes from it not working, including to the people trying to look after the people because it's taking its toll on us as well. And yes, there's money needs to be thrown at it, but in the right way to the right people with the right plan. And at the moment, there isn't one, but it's
Step.
not
You need
hard
to.
to do
I'm going to
the right
interrupt you
thing.
here. Do you know why? You got to explain to me what does a wraparound care mean? I haven't been able to understand the whole thing
For
about it.
obesity care,
Yeah. What is
okay,
this wrapper? What is? Tell me a little bit because nobody's been quite explained it to me. But it seems like something that all companies are talking about. All digital companies. We're
yeah.
going to provide. Is this? Well, tell me a little. What is it? Is this like a scam?
It's not a scam. But I think it's part of obesity stigma, okay? Because what they're saying is basically fat people can't be trusted to do this by themselves. That's
Oh,
basically what it is. Now, I absolutely agree that obesity is multifactorial, and there are people who have big psychological needs. There are people who have big social needs. There are people who would benefit from chatting through with someone who knows about diet. And there are people who will benefit from exercise or activity, help. And so I don't want those things to not be there. But what we shouldn't be doing is presuming that every person with obesity needs all of those things. That's just patronizing crap, quite frankly. And it's showed by the fact that most people who are doing things online privately are taking the drugs and not really needing it. Now, I know that there are people who are, and I'm fully aware that those services are required, but not for everybody. And but the belief, this firmly held belief that everyone with obesity is not capable of looking after themselves
do you know what is
really,
funny?
really annoys me.
Let me tell you what is funny. The reason I put that question forward is in 2018, when we're looking at why does an uptake of insulin pumps happen? It's
Okay.
because all specialists, most specialists and academics who had built all these theory had said, Partha, if they don't come and do this education program, which is over 5 days, they will never learn how to do the pump. So one of the things I did, I looked around, asked everybody, and they were like, well, I can't turn up those 5 days and I can't have all the
Mm,
support. And some people, well, I've learned it on YouTube. Thank you very much.
yeah, yeah,
So what we did is that we said, no, we're going to loosen that up. We'll do it online and stuff like that, etc. And that's what opened up the door. So I just find it fascinating how this seems to be repeating the same trajectory of
yeah,
the system being more, paternalistic, if that makes
yeah,
sense, about I'll tell you what you should do, and I also limit the sort of as to who can get it.
yeah,
Wonderful,
yeah.
wonderful, wonderful. Okay. Tell you what, so we're running out of time. So,
Okay.
last few things. So, from my end, you've been a wonderful advocate, and I think it's a sign of the times and that frustration, as you say, that with all the talent and all the ideas and all the enthusiasm you have to turn to another sector to provide that, which is probably where the NHS is heading, sadly.
Yeah.
Um, what would be your words you would leave to people who are in this space trying to lead it? What would you advise be to them? I mean, if it was down to me, Steph, I would put you in charge, but it's not down to me.
Yeah,
But
sadly, no one wants me to be in charge because I don't toe the line.
but that's the thing, isn't it?
Yeah.
Yeah, but
Yeah.
that's the irony is that you cannot change it without mavericks in place because they will never bring that other dimension to play. But that's a
No.
different matter altogether. But what advice would you leave for the people who are there, whose job is to make this happen, but clearly are struggling?
Talk to people who live with obesity is the first thing, because we are a bunch who are across society, and different people will have different needs. So that's the first thing. The second thing is separate out prevention and treatment.
Hmm.
Stop thinking you can treat obesity by telling people to get on a bike. That's just not true. So let's separate out those two things, put all the social stuff into the prevention
Yeah,
and the medical stuff into the treatment. And that's huge. And then understand that this is a lifelong condition.
yeah.
This is not something that goes away. I know that I am going to have to think about my weight for the rest of my life, and
Mm,
that's fine. And I
yeah,
now have a tool that
yeah,
stops it being
yeah,
horrible.
yeah.
And the last thing is that people with different amounts of body fat. So people, I mean, I don't like BMI, but let's go with that. BMI of 60 does not benefit from a 12-week commercial weight loss company or a dust diet. They need something bigger. They probably need surgery and they probably need meds. That's different to someone who has 8 kilos to lose, you know? And so those would be my big four things that people have to
Fantastic.
remember and act upon.
And here is something I would probably add in the mix to them is that I think the powers that be need to sit down, look at what NICE are approving, and decide where to invest. NICE's job
Yes.
is to look at it and say, here is something which is cost effective or will give
Yep.
returns.
Yep.
That doesn't mean everything needs to be funded.
Yep.
Sometimes you'll have to make a decision as a health system. These are my priorities. And I would strongly encourage people to say, these are my top four guns, and we're going to put everything into
Yep.
it. And then
Yep.
the other ones, you need to have a conversation because you're smaller groups, because that's not a population game changer, if that makes sense. And
Yeah,
as you
yeah,
said,
yeah.
with
Absolutely.
everything that's coming through, that will happen more and more. So you need to be ready now.
Absolutely.
Wonderful. All right. Fantastic as ever, Steph. Thank you so
Oh,
much for
lovely.
your
Thank you for
time.
having me on.
No, it's good. I think it's
Great.
good. I think we should have more of these where people can come out and talk and challenge. I think, as I said, somebody as amazing, and I'm not saying this because it's you, but you're so passionate. You want to help other people and their lives, and we have got a health system which should accommodate that passion and
Yes.
desire, is my view. Has to. Otherwise, you can't turn around and say, "Oh well, why is it?" Well, people are not walking away, but people are turning to other avenues to help people when we could do it.
Yes. Yeah. Yeah. But
Okay,
thank
well,
you.
any final words, Steph, before we wrap up?
I think that we need to let people be comfortable in whatever size body they have and treat them with respect, whatever size body they have. But let's help people to get comfortable to move through the world. That means
Perfect.
everything.
On that beautiful note, thank you so much, Steph, for your time, and I
Thank
will close
you.
it here. Thank you so much.
Thank you.